So this is a potentially very juicy discussion on food politics and policy, which we're going to dive straight into. It's a huge, huge topic. I mean, as you've heard, it encompasses, everyone's still arriving, it encompasses food systems, which is an extremely complex area covering health, food production, economics, trade, schools, employment, urban planning, social determinants of health, education, housing, at an individual level, identity, culture, value, and also should incorporate sort of societal values of sustainability, justice, and equity. Given that it's such a huge topic, it's going to be impossible to cover everything within the time that we have. So the way we've sort of decided to frame the discussion is about thinking about evidence-informed policy. What challenges are there to achieving that, and how can we move further on this path from knowledge to effective action? So we want to discuss, the challenges, definitely, but we also want to really think about the sort of solutions and moving forward. And keep in mind that it's not just a particular diet, but also about availability, affordability, and Sonia's really key point about equitable access to health for all, and where does food fit into that. So I'm really, really delighted to have this wonderful panel, who I will ask, for those we haven't heard from already, to introduce themselves and give their conflicts of interest. And we're going to start just by tackling the question which the panel have had a chance to sort of think about already, which is their opinion on what is the biggest challenge to evidence-informed policy in nutrition as it stands at the moment. And for Günter and Nina, you'll both have maybe 3 to 4 minutes to discuss that. For everyone else, 2 to 3 minutes. And we'll start with you, Nina.
All right, well, thank you very much. I'm delighted to be here. My name is Nita Teicholz. I'm a science journalist and an author. And I'm the executive director of a group called the Nutrition Coalition, which is devoted to ensuring that nutrition policy is evidence-based, so our topic. My conflicts of interest are that, well, for 25 years, I ate a vegetarian-ish or plant-based whole food diet-ish diet, on which I was rather plump and sick and most of the time. And then when I started reading the science on low carb, I switched to low carb. So that is what or low carb-ish, which is what I eat now. I also wrote a book called The Big Fat Surprise, and I receive some royalties from that book. But I think it's more important than the financial conflict of interest that presents is the intellectual one, which is that in that book, I came to, in the course of 10 years of research in doing that book, reading thousands of scientific papers, I came to the conclusion that I did not think that our nutrition guidelines were based on rigorous evidence. So that's a financial intellectual conflict of interest that I come to. One of the things that I think everybody in this room really agrees upon, despite disagreements, is that obesity and diabetes are tremendous problems, and it's an urgent issue that we all seek to try to redress. And the standard explanation for why we have obesity and diabetes in America is that we really fail to follow our dietary guidelines. We have nutrition guidelines, but we fail to follow them. So as a journalist, I really wanted to see if that was true. So I went and looked at our best available government data, and I found that surprisingly, Americans had done a pretty good job of following our guidelines. Since 1970, we eat 35% more fruit. Oh, I'm going to get these numbers wrong, so I wrote them down. 25% more fresh vegetables, 35% more fresh fruit, 28% more grains, and nearly 90% more vegetable oils. All things that we were told to increase, we've increased. Meanwhile, we've decreased red meat by 28%, whole milk by 79%, animal fats by 27%, butter by 9%. Everything we've been told to decrease, we have decreased. So, and this is true of every food category that you can find that the government reports on. Fish is up, nuts is up, yogurt is up. So everything that we've been told to do, we seem to have done. And this also holds true in macronutrient categories. Since 1965, we've increased carbohydrates by more than 30%. We were told to increase our grains, eat 6 to 11 servings of bread, basically a day was how it started. And we've decreased fat consumption by 25%. These are all American numbers. So again, in macronutrient terms, we have followed the guidelines. And also, in terms of exercise, we have, in the last 15 years, we have gone from only 40% of the American population meeting our federal government's activity goals to now more than 50% meeting those goals. So this explanation that Americans fail to follow the guidelines and we don't exercise enough is just simply not supported by the available data that we have. And this really opens up the question well, is it possible that the guidelines themselves have not given us good advice? Is it possible that we have followed the guidelines to the very best extent possible, but that we have failed somehow in the advice itself? And this is something that I actually went in to look at the whole evidence base for the guideline, and I took every single study for every single key question that had been asked about nutrition and health and put it in a spreadsheet and looked at everything and came out with some surprising revelations, which that the evidence base was surprisingly slim. For the diabetes, the idea that any of our dietary guidelines can reverse diabetes, the evidence was judged to be limited to insufficient. For obesity, there was a single trial showing that obesity could be reversed on any of our dietary guideline patterns, and that trial was only on 180 people. All the other trials had only lost only 1 pound. Okay, and also the data on heart disease was also very limited. So these findings, I just want to say one more thing, were also backed up in a recent study by the National Academy of Sciences, Engineering, and Medicine, which came out in 2017, which said, amongst many things, that the guidelines really lack scientific rigor, that the process of systematic reviews of the science were not state-of-the-art and needed to be strengthened. So I think the fundamental problem is that we do not have guidelines based on good, rigorous evidence.
Okay, thank you. So I'm going to go across the whole panel, and there'll be plenty of time for questions, I hope, as we progress. So Günter, over to you. The biggest challenge, but introduce yourself first.
Good morning. My name is Günter Hemrich. I'm coming from the Food and Agriculture Organization of the United Nations. And as such, I have an interest in the goals of FAO, which are 3, which is ending hunger and malnutrition in all its forms. But to do that in a way that also creates livelihoods and reduces poverty in the rural sector, and as well as protects the natural resources and manages the natural resources sustainably. So it's 3 goals where nutrition is one of them. In terms of my personal diet, I have no dietary restrictions. I eat the food that is available and accessible to me. And I do that in a way that I follow basic principles of healthy eating with a clear preference for home-cooked meals. In terms of what is the greatest challenge for evidence-based policy making, I would like to take us back to yesterday. Yesterday evening, I thought the whole struggle in this room seems to be how to generate the best evidence. This morning, when I listened to the 2 presentations, we talked more about the spaces where this evidence is being applied. And I think the greatest challenge for evidence-based policy making is how to feed the best available evidence into the policy processes that we have around the food system. That means about the way that we produce food, that we distribute food, that we process food, that we market food, that we bring food to the consumer and finally consume food. So what does this best evidence around nutrition have to do with the food system? That, I think, is the key challenge. And thereby we have to realize that these policy-making processes, they are not linear. They're quite messy at times. They involve multiple levels, multiple actors. There are some actors in the public space, some are in the private space. We heard all of that this morning. And I think the challenge is to create a new culture of dialogue within among all these actors in a way that really takes the best evidence available to the points where decisions are being made.
Wonderful, thanks. Nita, over to you.
Hi, I think we met yesterday, but I'll say a little bit more. So I'm trained in medicine and endocrinology. I'm a public health physician, and I'm a nutritional epidemiologist. I'm a professor in population health and nutrition, and I lead a research group in nutrition and health. So what are my personal, and I sit on many committees. So in terms of being an advisor, I have worked with committees on NICE in the UK, the National Institute of Clinical and Healthcare Excellence, with Public Health England, and also engaged with the POST, which is the Parliamentary Office for Science and Technology Communication, to inform the ministers. And I've also worked with advocacy and other agencies such as Diabetes UK and with International Diabetes Federation in terms of diabetes estimates and guidelines for diet. So these credentials are also potentially biases and conflicts, because over the past several years I've been building an interest and indeed a passion in trying to generate the best possible evidence that we can, and collaborating with others to learn from others and to work with others. My very personal bias is that when I was a medical student, I gave up red meat, but when I started working on the wards, there was no food to eat if you didn't eat meat. So I quickly started eating meat again. But now I do avoid red meat for various reasons. And one other personal bias I think we should consider is that as a person of an ethnic minority group from India, as a UK citizen, having grown up in India and now acculturated into Britain, I take at least two perspectives, and I'm always very aware of guidelines and policy that should be relevant across different population groups, and how research is often missing in populations of different ethnic groups. So those are my interests, but also potential biases. In terms of what is the biggest challenge, well, I think there's no one biggest challenge. I think there are several challenges, which I hope we will discuss. But to start off, I think the question is, what is the biggest challenge in evidence-informed policy making? So I think that evidence itself has to be a central part. Now, as Sonia covered in her talk, the knowledge for policymakers is a critical, important part of making policy. Knowledge for policymakers comes from very diverse sources. They don't listen only to the academics, for instance. There are numerous voices and multiple stakeholders. So I'd like to see more on the role of academics and academic institutions in more proactive engagement with direct communication with the public, with stepping out of their offices and being part of the conversation, being out there and sitting on bodies that appraise evidence for policy. And sorry, one more thing to add in terms of that knowledge, the information and the publications and the evidence base that is built up is drowned out also by a lot of competing noises and other information, because like pretty much any other field, nutrition is just something so palpable, so tangible to every single human being that it is, everyone has an opinion, and it's delineating what is good science from what is just noise and opinion. I think that's a really critical factor as well.
All right. Thank you. Sonia.
So I would say first and foremost, while this conversation has been very rich about where the evidence is, I think there are some very clear ways that we can act now that the evidence is strong enough that we absolutely have no reason not to act. And so while I think as science is, as it evolves, we will learn more. What I'd really like to emphasize in my comments here is our failure to act on the evidence that we have that we know will save lives. I think the biggest barriers are twofold. Number one, it's resources. Public health and prevention is extremely underfunded relative to its impact on health, on society, on productivity, and on our communities at large. In the United States, 3% of healthcare funding of the government goes to public health and prevention. 3%. 75% of healthcare resources goes to treating chronic diseases. We're investing our money on the wrong side of the equation. And if we invested it, reapportioned it, thought about ways that we could use that money to invest further in the development of knowledge and understanding, and then not waiting but acting now and really investing in our communities, not only about what somebody should have on their plate today, but really thinking about what communities, particularly communities that are disadvantaged at this point, need to change the environments they live in, to really invest in that understanding, and then finally to do the appropriate surveillance and evaluation of those really remarkable programs that are happening all over this world, and investing the resources in being able to write it up and disseminate it. That is what we need across the continuum. We can act now. It's not a question of not acting. It's about really ultimately having the resources to be able to act efficiently and effectively.
Finally, Martin.
Thanks. Well, you know, most of the points I'd written down have been said already, so I don't have a lot to add, and at the risk of repeating myself, I'll just maybe emphasize one or two points that I made in my talk. So I was going to make the point that Nita made about policy being evidence-informed, and how policymakers draw on a wide range of different types of evidence, not just scientific evidence. And I think that's really important to understand the policy-making process and what kind of information that is based on. I was going to make the point that Sonia made about resources, which I think is incredibly important, but also the points you made about urgency. You know, I think the biggest challenge is not about defining a healthy diet. We know enough to start right now on specific issues. We've heard a lot of talk about SSB taxes today, and there's very good evidence about the damaging role of free sugars. So, you know, we don't need more evidence to translate that knowledge. And we need to act with urgency on things that we know about. So I think that's really important. We have to, you know, I think as a group of academics and as professionals, we have to stop procrastinating. And we have to also recognize that there are vested interests that are disrupting our scientific process and are really enjoying the fact that we're arguing about these issues, because it is just slowing down the policy process, and that is of interest to certain groups. I think the biggest challenges relate to whole system change, as I said in my talk, and I say this because we won't make an impact on this huge global burden of diet-related disease unless if we kind of tinker around the edges of the problem. But to achieve whole system change needs strong leadership from government and, you know, to an extent from us as academics and from people working in the policy world as well. And we need a global dialogue, you know, with and involving major food companies, leading to a commitment to change. So, you know, I think in summary, I would say that the challenge is a political one.
Okay. So we're going to open it up for questions. So if you have a question, please put your hand up. Okay, so we'll start at the front here, and then I'm just looking around. Sorry, it's very difficult to see up here. Oh, sorry, gentleman there as well. So if you could, do you have a microphone? Where are the microphones?
That was the wrong person.
Thank you. Shimon Ray. I'm the co-founder of the new BMJ Nutrition Journal, as you heard previously. I just wanted to ask this panel what your thoughts are on the interface between policy and practice, because very often we use those two words together, but I think there is still potentially a step between lip service in terms of practice and bringing things from lip service to the health service. So we've talked about and heard about the roles of various different actors, but what about the role of empowering health professionals, healthcare professionals, and medical professionals in particular as advocates for sound nutrition practice?
That's a great question. Who'd like to take that one? Nita?
I think that's a really critical factor in moving from giving the policy to its implementation and real action. And this is a topic we have covered in some of the articles within this BMJ series as well. So a point that we covered, for example, in our diabetes prevention and management article is on the fact that healthcare professionals, doctors and nurses and specialist diabetes nurses, most of them do not get trained in nutrition counseling and do not have the skills or even the time. In many settings, what happens is you go and see your doctor, you're newly diagnosed with diabetes, you're given a long list of prescriptions and you go home with it. They may, if they're good in some settings, mention the fact that, oh, well, you should eat better, and they will give one menu to take away. And I've witnessed this in practice in certain settings. So nutrition education in the medical curriculum is really important, and allowing time and resource. This goes back to the point that was being raised previously on, if you have 2-minute consultation time with the person in front of you, where are you going to build that in? And even having the tools, in our clinics, we ask about, we get rewarded in some countries as GPs to document blood pressure and HbA1c levels and lipid levels, but where is the reward, so to speak, or the incentive for asking about diet and physical activity and so on? So yes, absolutely, it's part of the solution.
I think a couple of other panel members want to talk about it. So Nina.
Yes, I just agree with everything that you say. It's so important for healthcare professionals to see, they're so used to just dispensing pills, and they've been taught to dispense pills, and they don't have time to talk about nutrition. And I would add to that the other major problem is that when they do dispense advice about nutrition, that advice comes directly from the dietary guidelines. And it's interesting how little. So first of all, those guidelines are not evidence-based. They're not based on rigorous evidence. So they're giving advice even to, say, diabetic patients to eat a high carbohydrate diet, which is certainly not what a diabetic patient should be told. And there's a tremendous constraint because the medical system is so rigid that doctors actually have very little leeway to, if they know anything about nutrition, let's say they know that maybe a low-carb diet would be better for a diabetic patient, they are not allowed to give that advice because due to all the limitations of the system. They might be sued, they're part of a large medical practice. So I've heard time and time again from the doctors' groups that I'm in that they simply cannot, they're not allowed. One said, I take the plate from the dietary, the Eat Well plate, or what you call it here in England, and I just cross off the starch half of it, and I give that to my patients. So they're very limited in what they can do in terms of giving good advice.
I know that we have some sort of clinicians and people involved in diabetes charities who are working on that. I'll just allow Martin just to say something on this point about.
I don't disagree with what Nina and Nita have said, or what Shimon has said for that matter, but I think the importance of what Sonia said about resources needs to be borne in mind here. If we have a limited pot of resources for things to do to improve diet globally, this would not be my top priority. There is an opportunity cost with spending money on one thing which you then don't have available to spend on something else. And I think our top priorities are to change the global food system, and I'm just not sure this is the top priority. There's nothing wrong with what any of you have said. It's important work, it will help improve things and so on, but just that note of caution.
And I suppose the other note of caution, or not note of caution, but is to remember that we have, as a doctor, we have colleagues who are trained in nutrition, dietitian colleagues who can also deliver some of this education to patients as well. More questions. I'd like to take 3 questions. So we have the gentleman with the blue there, and this gentleman here, if the microphones could, we have one. Okay, so we'll take one question there, and a 3rd question here. So if you'd like to go first. So.
4 of the 5 of you seem very sold that government should be very active in this process. Clearly, it would be great if government was effective. Ms. Teicholz mentioned that the guidelines have been essentially followed and not resulted in good results. Could I just ask for the other panelists to respond to that? Perhaps she's wrong. Is she right?
Okay, thank you. And you, sir?
My question, I'm Dr. Schmidt, 63-year-old gynecologist practicing here in Switzerland. Fortunately, we're not restrained, probably like the doctors in the United States. But here in Switzerland, also I add, I'm a type 1 diabetic, insulin dependent, and I treat patients with gestational diabetes. And so, fortunately, low carb is not an option. There is no other option. Sarah Hallberg said, yes, we've got low carb, we've got bariatric surgery, and bariatric surgery is not an option, and there's not an option for calorie restriction, especially not during pregnancy. And so my question is how, as I and as an individual, not representing a group or a company, how can I work to bring change to improve, as an individual, dietary guidelines in any country, but especially here in Switzerland? Thank you.
Thank you. Good question. And you, sir?
Dr. McCarran, again from UC Davis and the American Society of Nutrition. Sonia and Martin, and Sonia specifically, you indicated the success of the program that intervened with both retailers and food manufacturers over the last 9 to 10 years in the UK. Sonia, you stated 20% reduction. Thanks to the Apple Corporation, I'm looking at a graph from the MRC, published about 18 months ago, and it's urine sodium. As a nephrologist, I understand this is the one nutrient we can get a pretty good handle on, and there is absolutely no change in the urine sodium. I think the idea of the shaker was good, but can you prove that you've changed intake? Because the MRC data says you have not.
Okay. So those are 3 very good questions. So first, we've had a response from other panelists about this put forward by Nina that dietary guidelines aren't evidence-based. Then we have a question about how can an individual impact on how guidelines are formed for perhaps an overlooked population or a population that they're looking after. And then this question about, which I think is very, very key, which is how can you evaluate the health impact of policies as well. So who'd like to respond to this point about dietary guidelines and their evidence base?
I can start.
Okay,
off. Yeah,
go ahead, Nita.
Sure. Are dietary guidelines evidence-based? Well, depends on guidelines where and for what. So there are specific guidelines which are based on guidelines for nutrient intake or for micronutrient deficiencies. There are guidelines for food-based guidelines, and some countries have them, but also bearing in mind the global perspective, some countries have none, or they borrow them from countries where they exist. So that's the first point to note. Secondly, are they evidence-based? Depending on those factors, many of them are. Some of them are very poor, but the sorts of guidelines we've been discussing in much of the Western world, they go through great lengths and have very detailed step-by-step processes and structures and frameworks for taking evidence from all forms of study designs, and they follow what is the current hierarchy of evidence, whether that hierarchy of evidence that is established for pharmaceutical products and for other fields in medicine, for technologies and so on, how relevant and directly relevant that is for public health issues, including lifestyle factors such as diet and physical activity. That's a topic in its own right. To what extent we need to revisit the hierarchy of evidence for this field. But are they evidence-based? Absolutely, they are. They use the evidence that is available, the best evidence available at the time.
Could they be more agile, more responsive as evidence emerges?
So that's an important consideration going forward in the future. The guideline process can take a long time because of the evidence generation itself, which takes time, but also then for committees to sit and sift through that evidence and by the time it's incorporated, it can be 2-3 years long process, or even longer in some cases. So can that be speeded up? I think we need to look at more dynamic ways of updating evidence, perhaps a continual program of systematic reviews.
Okay.
I know the World Cancer Research Fund, WCRF, works somewhere towards that goal. So
Okay.
I think other dietary guidelines should.
Okay, Nina, I'll allow you to respond very briefly to that. Günter, I'm going to ask you to, after that, to take the question about how to influence what policy gets made if you're an individual or if you're interested in a specific population. And then Sonia, perhaps you can touch on evaluating impact after that, responding to that question. So Nina.
Yes, so I would just, it would be my great dear hope that everything that you say is true. I mean, that is true that experts, they spend a long time reviewing that, and they spend great resources and time going over the evidence, but it was, in fact, the conclusion of the National Academy of Sciences and Engineering and Medicine, which was the first ever outside peer review of the US guidelines. They'd said that the standards of reviewing the science did not meet state-of-the-art practice for systematic methodologies. And they do use a systematic methodology that is specific to nutrition and nutrition outcomes, disease outcomes. So that has to be taken seriously if they're not reviewing the science adequately. And one of the things that I found was that somehow, in the course of reviewing our guidelines, that the vast majority of clinical trial research that had been funded by the National Institutes of Health on more than 75,000 people, the most important clinical trials ever undertaken by our country, had never been reviewed by any of the dietary guideline committees since 1980 when they were launched. So how does that happen? A good process should not omit the large clinical trial basis, the rigorous evidence that we have, that should be used in policymaking.
Okay.
So, so I think there are just problems that we don't know about, but that are there.
Okay. All right. Well, moving on to this next topic about how people can inform and influence this process of policy, particularly in an area like gestational diabetes. Okay. Or overall.
Yeah. No, I would like to go back first to the question around food-based dietary guidelines.
Okay.
And on the FAO website, you will find a site where there is a whole list of the global guidelines available, and they vary a lot in terms of quality, in terms of depth, in terms of whether they include sustainability criteria or not, in terms of how they look at ranges or specific recommendations. So there's a huge variety. Is there scope for improve the quality of these guidelines based on the latest evidence? Certainly there is. But it's all dependent also from government capacity and for the willingness of investing in these processes. One point I would like to highlight is that these food-based dietary guidelines have really always determined the interface to the consumers of food. I think it's equally important to shed a bit of more light on what do these food-based dietary guidelines mean within the context of food and agricultural policies, and to make back the link to the policies, because if the food that is recommended is not available in the countries where the guidelines are implemented, it's useless. And similarly to the question on policy and practice, when there is no policy implementation capacity, it doesn't make sense to develop policies. So what we have done in FAO is we have done 5 regional workshops on sustainable food systems for healthy diets and improved nutrition, where we started actually with the country experiences. What have countries tried to do in the area of improving nutrition through food systems actions? And then from that, build up a dialogue of what worked, what didn't work in the different countries. We don't give concrete prescriptions, but we provide this platform for exchange. And I think that's very useful. And that also applies to the food-based dietary guidelines.
Okay. And then on evaluating the impact of policies, particularly on, I guess, health-related clinical outcomes. Sonia, is that happening, or how easy is that?
I think it's just a really important point that we really need to continue to invest in our surveillance, evaluation, and monitoring systems. One of the things that's been remarkable about this last century was the impact we've made on communicable diseases. That happened not only because we were aggressive in creating policies that changed the environments we live in so that we all stay a little healthier, we're not as exposed to some of this bacteria, but also because we were dogged about developing monitoring systems and evaluation systems that are rapid and that really help us understand whether or not our drugs are effective, whether or not communities are being contaminated. These kinds of investments have been incredibly important. They should continue. But we should also recognize that it's now chronic diseases that are killing people, and so we must put in place surveillance systems that help us understand the impact of our policies, particularly nutrition, on health. So for example, 24-hour urinary sodium is the gold standard right now for evaluating sodium intake. Those studies need to be conducted. We need to concurrently invest in understanding other ways of evaluating sodium intake, because sodium is a problem in our diet. It's increasing blood pressure. It's causing deaths that could be avoidable. So if we had rapid ways to be able to understand how our policies are affecting our sodium intake, it would be much easier to be very rapid and nimble in the design of our policies. So I think this question of investment in evaluation and investment in policies needs to be a concurrent conversation, and we need to really value both of them equally.
And Martin?
Yeah, so, I mean, I agree. The challenges, though, of evaluating intervention, like, you know, the salt shaker intervention in a real-world context cannot be underestimated. We had a very low budget for that particular work. It was small scale, and we were kind of undertaking iterative science. You know, we did the lab work and then the study looking at the sodium content of the meals, and then we ran out of funding. And clearly the next logical step would have been to look at its effect on humans. And you know, we weren't able to do that study, but that is the next piece of work that needs to be done. You know, but we have to be quite clear about the limitations of existing methods in those contexts. It's very difficult to conduct a randomized controlled trial of people who use fish and chip shops. And so, you know, we're into the territory of natural experimental evaluations, and those, of course, are challenging and, broadly speaking, are observational in their methods. But that is the best kind of evidence that we're going to generate for those kind of interventions, and many policy interventions, like soft drinks taxes and so on, are evaluated using those methods.
Okay. I'd just like to ask a question, just to sort of move us forward to start thinking about how we can sort of speed this up and make these decisions sort of easier. One of the things that I'm struck by is who gets a seat at the policy table. And, you know, Martin, you touched on the role of the commercial food sector, and Nina, you mentioned the vested interests that can often influence dietary guidelines. So how, and then thinking about other sectors as well that are involved in the food system. So how do we take all of that and sort of use that? Is that happening anywhere? Have you Günter, perhaps you can, and Martin, yeah.
Yeah, I just wanted to highlight a few policy processes that exist at global level, but also at city level. At global level, there is the Committee on World Food Security, which has produced a report on nutrition and food systems, and has yesterday approved a set of terms of reference for a 2-year-long negotiation of guidelines for improving nutrition through food systems action. So that process will roll out, and it's a multi-stakeholder process for governments, for private sector, for civil society, that will take place in Rome. So that's one policy process where the lessons from this meeting also can be fed into. There's also the Milan Urban Food Policy Act, so it's not all global. There's also cities that basically try to improve their food policies and their action around food. And there is stakeholder meetings among these groups that can basically share experiences of what can be done at local level and at city level in terms of improving food security, nutrition, in terms of all kinds of entry points of actions. It's not only health entry points. And then I think it's really important to work at country level and to revisit the way that national food policies have been done. Because in the past, I think very few of these have actually looked at where the food is coming from. And the food systems approach really helps to look at nutrition in a very different light. And I think this is a process that should start. The last point I wanted to mention is that at global level, there is also an initiative for a global dialogue that brings together private sector actors. And I think this is a very, very interesting experiment. It has just started last Monday in Stockholm at the EAT Forum. And it's a process to be followed. There's no details yet in terms of how it will be rolled out, but it's something to keep in mind and to see whether this is something to upscale this dialogue.
Well, Martin, we've heard about the lack of public health funding available for this. So we have an industry that has has all this turnover that you said. How does that relate to what we can do here?
So yeah, the resources are in the hands of the private sector, obviously, and it would be good to see some of those funds to contribute to solving the problems that may have been contributed to by the food industry. I think we have to be careful, though. We've talked a lot about conflicts of interest here, and the interests of the food industry and how their money can be influential are extremely important in this space. So I think that issue of where the money comes from, what influence it's having, and so on, needs to be thought about very, very carefully. There is the potential for abuse. I think the second issue is that yes, we need multi-stakeholder involvement, but stakeholders bring their expertise with them as well as their interests, and that's what we're really interested in. But one of the things that happens, and I've seen it happen, is that people don't necessarily stick to their expertise. So, we want to see the public health experts bring their public health expertise, the academics bring their academic expertise, whether you're an epidemiologist or an evaluator or whatever. And we want to see people from the business world bring their commercial expertise to the table. I don't want to see people from the commercial world speaking to a select committee and talking about health. That's not their domain. Come and tell us about the commercial challenges of implementing healthy public policies in the commercial sector. So, I think there's a really important kind of governance framework that's needed around this whole idea of multi-stakeholder frameworks.
I just want to add to that the importance of transparency is so important. One of the points of the National Academy of Medicine report that I keep mentioning is that these expert committees that we're talking about that make these decisions, they do not necessarily disclose their financial or intellectual or dietary conflicts of interest, as we have done here in this room today, which I think is extremely important. And that not only those conflicts of interest, but really the bias that John Ioannidis talked about. There are clear biases that at the expert level that we see that are strongly held and are, again, not supported by rigorous evidence. I mean, the bias against red meat that we've seen on all the epidemiological slides, there are no clinical trials showing rigorous randomized controlled clinical trials showing that red meat is bad for health. In fact, the clinical trials that do exist show the opposite. So I just think it's important that biases be managed, conflicts of interest be managed on all these expert panels.
Okay. We have three more questions coming. So we've got the gentleman at the back, we've got one question here, and then the lady there. So if you've got a microphone, so try and keep your questions short. Please introduce yourself before you give your questions.
My name's Ian Lake. I'm a GP and a clinical advisor for diabetes.co.uk. We've heard a lot this morning about food labelling as a way of improving health. What proportions of carbohydrate, fat and protein would each panel member put on the package in order to achieve that aim?
To do what?
Okay.
To get what?
Sorry.
I don't quite understand the question.
Can you, we're just asking if you could repeat the question.
Yeah, we just want to know if you had the chance to direct food labelling in order to improve overall information on health, what percentage of carbohydrate, fat and protein would you put on the label?
So what's the macronutrient composition?
You mean limits? Or?
The limits or the ideal amount?
The thresholds.
Okay. And Mike?
Mike Lean here from Glasgow. Firstly, a quick point of information. Dietary guidelines for diabetes for the last 20 years have all not been for high carbohydrate diets. That was not correct. They've actually stipulated a range which can be made up either of high carbohydrate foods provided with natural fiber and legumes or with fats. And that's been the case in the European-wide guidelines for over 20 years now. And I would want to pick up for my question Nita's point about the role of the academics and in our guidelines. The same guidelines have consistently said that foods which are being marketed for people with diabetes, so-called diabetic foods in supermarkets, have no benefit at all. And indeed, they have the opposite. They have detrimental effects because they identify individuals and stigmatize them, and they have often increased calories and cause weight gain. We made recommendations, and they've been consistent for 20 years. They haven't been acted on by anybody. In fact, whenever these recommendations come out, industry increases the marketing. We had them removed through John Krebs's efforts in the UK for 2 years from the supermarkets by agreement with the supermarkets, but after increased marketing by many German companies, they're back on the shelves. People with diabetes are being flooded with these products. What does policy have to say about that?
Yeah.
Respond to the thing that he said that I said.
We're just going to get the final question first. Yeah. Thank you.
I'm Stephanie Baldavich. I'm a consultant endocrinologist in London. So I'm running the clinical department for diabetes and endocrinology at University College London Hospitals. My question, however, is slightly wider than goes beyond London or Europe. Do you think the future guidelines should take into account the environmental impact of food choices we make? So I know the guidelines are for the individual, but should we also consider what this means for the planet and for the humans as a group?
Okay, so we have a question about food labeling and what level of macronutrients you would put on them. Then there's a question about guidelines, and I guess the kind of commercial buy-in to those and how, in order to enact them, I suppose is that question. And then a question about in policy being informed by environmental considerations, which I think is really key. So who would like to take the food labelling? We'll just be very brief because we've only got a few minutes left.
I can quickly comment. Yeah, the one comment I'd make about food labeling is that every country that is working towards this now is spending a lot of time very carefully thinking not only about the levels, but how that is interpreted by the community that is going to use this information. Mm-hmm. And I think we really need to honor that. And so I don't think this is about one level is what every country should be using. I think every country should be thinking about this. Indeed, if they want to adopt policies that have already been introduced somewhere else, that's up to the country. But I don't want us to assume that things being brought in from the outside will be relevant to that community. Countries have to own their own solutions. And so my comment back would be that is a conversation that needs to happen one by one through countries, and they need to make those decisions about how best to communicate with their population at large, and that is a participatory experience.
Okay, and Martin?
Well, just to say that, this question of, I'm not going to comment on the levels, but this question of how the public interprets labels and so on. These are researchable questions, but we have an absolute dearth of research on how the public actually interprets labels. There's been some great research in the UK on traffic light labels, but it is limited in quantity. We need quite a lot more to give us a real understanding of what the public takes from a label and how they use them when they read them and so on.
Okay, and Nita, perhaps you can pick up on this point about what we can do about diabetic foods,
Well, I think the political climate is really important in that as well, because funnily enough, this is a point we raised in our article on diabetes, that due to European legislation in UK, we were able to get rid of the diabetic foods label, or foods for diabetics, as it's very politically incorrectly called. What happens post-Brexit to that, whether we retain it or not, that is something to think about. And in many countries, again, taking that global focus, in many countries, those foods are very much, there's a huge market in those ongoing. And I think it's really important to stress the point that whether or not someone has diabetes, whether you're part of the general population or of a patient population, so to speak, there is no space for foods that are labeled in that way. It's about the sorts of diets we were talking about yesterday, the evidence-based that we have on food-based consumption.
Just respond on the diabetes question to the...
Yeah, so we have Martin and then you go.
Oh, sorry.
So I think this is if I understood what you're saying, Mike, I think this is a generic question in a sense about regulation and marketing of food. We don't have a good history on this. In the UK, the government regulated the advertising of high-fat, salt and sugar foods to children in 2009. The regulation, the process of developing the regulations was led by Ofcom, the Office of Communication, which is a government quango, and the people they had round the table were from the food industry. The regulations were introduced. We did an independent valuation which showed that it had no effect. In fact, the amount of food advertising of junk foods increased. We have to understand the process of developing policy and how we get to this position. It's really important that we have effective regulation of food marketing.
Nina, very briefly.
Yeah, well, yes, I just want to echo this, which is that at the USDA, the U.S. Department of Agriculture that does our guidelines, when they have listening sessions about the guidelines, 90% of the people who come to those listening sessions are all from the food industry. When I was invited, I couldn't believe that I was surrounded by the food industry, and these were the advisors to the government. But just on this point that you said that I had incorrectly stated about the Diabetes Association, it's the medical doctors, not necessarily the diabetes educated. The medical doctors will give the standard dietary guidelines advice to their patients to prevent diabetes. And also the American Diabetes Association says they advise a low-fat diet to prevent diabetes. Once you get diabetes, then low carb, at least in the United States, low carb is an option, but it's not a heavily promoted one, is the best way to put it.
Okay, very briefly, because I'd like to use the last 5 minutes to just make some concluding comments, but this really key issue about environmental sustainability, which, you know, the evidence about climate change is that's going to be one of the key drivers of our health. So who'd like to just comment on that?
Okay, let me start with the guidelines and sustainability in the guidelines. In the review that we have done, there is about a handful of countries that have tried to build in sustainability into their national food-based dietary guidelines. So there are examples out there. In terms of FAO as an organization, we don't prescribe to countries to do this or not to do this. Sustainability is of critical importance. It's very important that the food system that provides the food is sustainable. How much the sustainability comes out of the consumption patterns is an issue that is heatedly disputed. I think there's very strong political opinions around that. It's important to keep that in our mind. I would like to close maybe my own statement on sustainability with another point that has not been made in the meeting yet. There's very few participants from Africa. In Africa, we have about 12, 13 countries that will double their populations by 2050 and double them again by 2100. They all live in fragile contexts. So there are enormous challenges, not only in terms of the nutrition transition, because all these people will largely live in cities and not anymore in the rural areas, the additional population, and their production systems will be very fragile. So I think sustainability and nutrition will be very high on the agenda in the future, and there will be definitely many more global dialogues needed that also consider the issues in the South.
Okay, thank you. Well, just for my final question to you all, we've just got a few minutes, and I'd like to give you just a few, maybe 30 seconds each. I'm going to give you a magic wand. Martin, you said that your priority, if you had, for sorting out this area, would not be educating doctors. So I'd like you to think about what would be. I'm giving you a carte blanche, magic wand. What's on the top of your wish list when it comes to policy and nutrition? Sonia, I'm going to put you on the spot and start with you.
Wow. I wish for so much. I think that where I would start is from the equity angle. And I wish that we all had in our minds, first and foremost, as we think about this, a vision of a world where we do have health for everyone, and that becomes the way we walk forward, the way we see the world, and the way we see nutrition in particular. And so when we're thinking about the debates that we need to have, we really start with that as central, so that the solutions end up being ones that bring us all forward together.
Okay, thank you. Nita?
More constructive and positive dialogue on the underpinning research and the sorts of evidence that can be used for public health guidelines.
Günter?
I think recognize the urgency of the global nutrition crisis and come to a new level and quality of dialogue that leaves stakeholder affiliations behind.
Thank you. Nina?
I wish for evidence-based guidelines, and where we do not have rigorous evidence, simply not to give guidelines. Because when I think of where we've gone wrong, we got it wrong on dietary cholesterol, the low-fat diet. We spent decades trying to retract guidelines that were not evidence-based. So let us just remain silent when we do not know.
Okay, and Martin?
I think I would wish that the governments require the food industry to pay for the external costs of the food that they produce, whether they are environmental, health, social or economic.